We've got Krista Burslam-Dawe from Opto Health. Is that right? And you're going to tell us what Opto Health are, and a jolly fine company. And we've got Mairead McCormick, who's the Chief Executive Officer of Kent Community Health Foundation Trust, and a jolly fine trust it is too. Right. So I think perhaps what we'll do is, why don't you introduce yourselves and tell us a bit about what you're doing and all this, and then we'll have a chat about the price of chips and where you went for your holiday, and we'll keep going till lunchtime. Okay? Far away.
Afternoon, everyone. Thank you for the intro. Mairead McCormick, Chief Exec of Kent Community Trust, as Roy says. I've been in this post for about 16 months. And I've got a background in acute care. And interesting, Krista and I have just discovered that we're both emergency nurses by background. So always quite interested in logistics. So I guess the patch that I cover is a wide geography across East and West Kent predominantly. So 95-mile radius between both. So huge population, huge geographical challenges. My own organisation is about 5,500 staff, covering all sort of pre-hospital care, preventative, all the range of services you would expect as a community provider. And we also deliver care on behalf of the local authority as well through Section 75, which Roy has alluded to in the previous section. My other part of the role, which is quite interesting, is the place-based leadership. And I am the place-based leader for East Kent, which is a particularly challenged area of Kent, with a massive challenge around deprivation, but also the coastal challenges, which people will be probably quite familiar with up and down the country, but it really is quite challenged in East Kent. So I'm quite interested in the logistics of how we get things done, but also that place-based partnership. I think Rima referred to it in the previous section of the relationships between healthcare and the wider partners at a place-based level. I'll hand over to Krista.
Thank you very much. Hi everyone. So I'm Krista. I'm the Chief Operating Officer for Opto Health. We're a digital triage solution for emergency departments and UTCs. My background is, I'm an emergency nurse, have been for 20 odd years, so have certainly lived and breathed the pain of emergency medicine over the time. And the reason we've developed Opto is because I've seen all the challenges, I've felt those problems, and I've probably triaged a lot more patients than I can imagine at the moment, and I've seen how things have evolved and the difficulties that we have. And I firmly believe in 2023, no patient should be walking into an emergency department, and it's dependent on the nurse that you see, depends on your process in that hospital. So we really want to standardise what's going on, but also to support those junior nurses that are now being put on their front door to make those decisions. So I can talk to you all for days about Opto, but come and see us anyway. We're on H10.
Okay,
it's a big plug there.
Are you a customer of Opto?
No, not yet.
Okay, but I mean, I can. If you've got a question, just put your hand up and we'll come to you with a microphone. But while you get your juices flowing, I mean, I can see a use for that kind of decision support mechanism, isn't it, really, in community where, I mean, community nurses really are very exposed, aren't they? From the decision point of view, the record-keeping point of view, decision-making. Do you use decision support at all, or do you just get on the phone and say, what do I do next? How does it work?
Yeah, we do. We don't do enough of it. And you're quite right. I think community nursing in particular is probably one of the most challenged workforce groups. And there are a lot of gaps. Difficult to recruit to, under a lot of pressure to manage caseloads and manage the geography and the growing complexity of the local population. And one of the greatest challenges of community nurses is actually logistics. The logistics of getting things to patients, the logistics of travelling to and fro, central stores, for example. and the amount and level of data input that they have to do for a variety of reasons, for governance reasons, for audit reasons. And we really are still, I think, quite basic in that data entry, which takes an extraordinary amount of time, and it's one of the things that I probably hear the most gripes about.
How do you do it now? Is it the folder and the pen, the biro, or can you use an iPad? I mean, what do you use now?
Yeah, so they use laptops or they use iPads. Some of them use smartphones, devices. So of course that's helped enormously, but it still doesn't take away from the burden of data input. I'm really keen to progress to voice recognition, to capture the consultation at a local level and an interaction with the patient, that they don't have to then come out. I mean, many of these people go out into their cars and input the data after the consultation. Absolutely bonkers.
Yeah, and there's Dragon, I think it is Dragon software, isn't it? I don't know if they're here, but that's a software system that specialises in clinical conversations and all the funny words that we use and take for granted. Well, I'll come to you in a minute, Krista. Just talk to us. We heard the first presentation this morning was about virtual wards. Now, I would think they're probably a nightmare for you, because when something goes wrong at a virtual ward on a Friday night, they're going to dump it on the community nurse, aren't they?
Yeah, so I mean, look, I'm a huge advocate for virtual wards. I think we've done an enormous amount in that space. I don't think they're where they need to be yet, but it is a fabulous way of managing caseloads. What you've got to make sure is that you've got the infrastructure around those virtual wards 24/7 to respond, because if they're not responsive 24/7, there's an inconsistency of offer and the patient falls over and enters an urgent emergency care pathway. We know the patients best because they're part of our community, so they need to be responsive 24/7. I'm not saying everybody needs to be on duty 24/7 to respond, but you need a local response.
And also before someone is accepted into a virtual ward, you've got to do an occupational therapy assessment of their home. I mean, maybe full of trip hazards, or they may need a perching stool, or they might need a raised toilet seat. I mean, all of that's got to be in place before you can even think about a virtual ward, and that's really right slap bang in the middle of what you do. So when they put up, how much money they've saved by doing these virtual wards, actually I don't believe it, because I think there's a lot of double charging going on, because you've got you and your overhead, and they've got them and their overhead, and there's a huge overlap in what you do. I don't know if you've got any thoughts on that.
Yeah, so I mean, as I say, I think there's there's a long way to go on virtual wards. I think we're at a really, we've progressed a lot in the last year. The part for me in virtual wards is enabling the person themselves to take personal responsibility. And to be able to navigate the system, because I think we do a lot onto people, and I think if you give people the tools on how to navigate and ask for help in the right way, patients at the minute or residents are trying to navigate various systems. What's a virtual ward? What's a complex team? What's the end of life team? We shouldn't be letting the resident or the patient trying to navigate at a really vulnerable time. So we've got to make it easier somehow for them to be able to navigate it.
And it's families as well. I remember when my mum was alive, the community nurse would come in and look after her, and the community nurse gave my mum her number and said, if you've got a problem, Edith, give me a ring. But my mum would always ring me first and say, do you think I should ring the community nurse?
Yeah.
You forget the role of the relative. Right, coming back to your wonderful product then in A&E, how is it? So we've got a busy A&E, we've got 17 ambulances queued up outside, we've got 14 trolleys in the corridor, and we've got 3 gaps in the rota, and there's more on the way. Discuss.
Yeah, no, absolutely, and that's been my life for quite a few years.
And I can understand why you've gone to work for another company.
And I've had to manage that. And what's really, really powerful is if you get the right decision made when that person first arrives, then actually that really helps the process with that patient's journey. What's currently happening at the moment is patients are arriving And actually, bottlenecks are occurring because those patients are being triaged incorrectly and they're going to the incorrect area of that department. So I was saying
Have you
earlier,
got any data on that? I mean, how common is that?
It's
you know,
very,
if you
very
work
common.
regularly in A&E, you get used to working with your team, you know kind of what you're doing. The moment somebody comes in on the trolley, you can think, well, that's got to go there. I mean, people have got that sort of intuition, haven't they? The instinctive awareness that comes over time. I mean, how long do they need the decision support, the kind of thing that you're doing?
I think you said it comes over time, and what's happening right now is very inexperienced nurses are making those decisions. So I used to come on duty every single morning as a matron, and I could have at least 10 patients waiting for hospital beds in my co-located urgent treatment centre. That was not the appropriate pace for that type of patient to be in, and that's because they were triaged to that area in the first place incorrectly. And therefore the wrong clinician saw them, there was a delay then in their care, there was a delay in their referral, and actually now I've got an urgent treatment centre that can't be used as an urgent treatment centre because there's no cubicle space for clinicians to see these patients. And they're your very, very quick throughput patients that needs to be seen by the EMPs. We've got prescribing pharmacists and EDs now, and they don't have any space to see those patients. You've then got patients that should have gone to the urgent treatment centre where GPs come on duty that are now in my majors area. So you've got patients in the wrong place being seen by the wrong clinicians. So the data out there is absolutely huge by looking at your DTAs first thing in the morning with who is in what area of your department. We're not putting people into urgent treatment centres just because that's the only cubicle available and that's the only trolley. They got put there incorrectly in the first place. So you can therefore see why EDs no longer work and all of a sudden they become blocked.
So walk us through, how does it physically work? So you know, the nurse is there, paramedics have arrived with somebody on a trolley. How, do they get out the iPad and do a whole load of yes-nos?
Yeah, so what we've done is created a solution that now standardises that process. So removes that unconscious bias, removes that human fatigue as well in triage. I know after 12 hours I get incredibly tired of triaging patients. I've seen the 50th abdominal pain that's come in that day. So without consciously doing it, you then kind of go, oh, another abdominal pain. And that's really awful as a nurse. You don't want to ever feel like that. So now actually patients come in, they use the technology, they use the iPads, they can QR code on their own phone as well, so they can use their own device. It books the patients in, it matches them to their NHS number, and then it starts asking all those questions that someone like myself, who's been triaging for 20 odd years, would ask if I was face to face in front of that patient. That unconscious bias has moved, that standardisation has happened, and the risk stratification happens behind the scenes. So we then can map that patient to the appropriate place. So you've now got co-located UTC patients going to your UTC and no longer holding up those cubicles. You've got majors patients going to majors. We can process map it to same-day emergency care as well. So we've got patients now that I can send patients to SDEC, to early pregnancy assessment units.
Yeah. Of course, I mean, there is the old thing about if you change how you triage, you put your consultants on the front door. And that makes a huge difference. We found that during the strikes, I think, that you put the consultant on the front door, you get a lot less congestion. I'm wrong. We get a lot less congestion in A&E.
Yeah, absolutely. And I worked during the very first junior doctor strike, and we saw 100 patients more that day than we had seen the previous day before the strike.
Yeah.
We had no delays, and our referrals were very,
I've got
very
a front
quickly.
row of junior doctors here, I think. We better be careful what we say, I think. You're all medical students, yeah.
No, but you've got to support our next generation, and you've got to support the junior doctors coming through as well.
Well, I mean, there's two things really. I think, firstly, I don't know if you've heard now about boarding. Have you heard about boarding? That's where people are in A&E and need to go to the ward. They know which ward they're going to go to, and they're just sent to the ward whether or not there's a bed. And they then put up an extra bed, or they keep the person on the trolley in the ward. It's called boarding. They've done it in Australia, I think, and somewhere else. I looked at it hasn't worked, and it's full of risks, but we're doing it here. And I suppose really your triaging thing might take some of the risk out of boarding.
Yeah, and that's a very controversial process because wards are full. and the expectation is that they take one more patient, but actually currently all the risk is sitting in the emergency department. So not only are the emergency department staff dealing with patients that are coming in because they don't have the luxury of closing their doors, they're the victim of their own success, to be honest. They never shut. It's a very good branding. Patients know about the emergency department. They know they can go there. So they don't have that luxury, but they're trying to not only deal with all those new patients coming in, they're also trying to deal with all those patients that should be in the appropriate place in the hospital, being dealt with by specialist nurses and specialist medical teams.
Yeah, I think the president of the Royal College of Emergency Medicine rather ill-advisedly said hospitals were reluctant to do it because the wards didn't want the extra workload. And I thought, well, you know, how insulting can you get, really? Everybody's on their knees with extra work, really, but he seems to want to spread the pain from A&E around the hospital.
I don't think anyone wants extra workload, to be fair, because that just increases risk,
Well,
doesn't it?
I think it's a bonkers idea, and they've stopped doing it in other countries, but we never learn and we don't listen. Coming back to the community and the source of all admissions, where are you? Where do you sit now with the ICBs? I mean, has that unlocked anything for you in terms of partnership working and so on that you couldn't have done before? Is there any benefit to you of ICBs?
Yeah, look, I feel very positive about it, and I think it's probably the first time where we've got all the right partners around the table making collective decisions, particularly in the financial constraints. And I think there's a very renewed focus on, value for money and getting the right outcomes.
There's a big opportunity. Carl, I'm just worried about the time. There's a big opportunity. I mean, GPs have an at-risk. Have we got any GPs here? You've got a GP here. Do you still do the frailty at-risk lists? Do you still do that? You were paid to do that at one time. Do you still do it?
Fragmentation of care is the problem. We now have a part-time service.
You still have a frailty list, yeah. So I mean, the GPs have got lists of people that are, we call them rather rudely, frequent flyers, but people that we know are going to need our help. And quite often that involves more than one agency to help them, really. And I'm just wondering, if you had access to his frailty list, if you had the resource to do it, and by resource I mean really people, you could do preemptive visits with people who have not actually called you out at all to say, hi, how you getting on? You could do like a trip hazard and a walk round and a walk through the place and see what you could do with other agencies to stop people coming into hospital. But you have to get upstream to do that, and it costs money to do that, although it saves money at the other end. But the NHS can never afford the dual running cost to make this stuff work.
So we are working with the GPs on the same lists of patients. So that's a really good start. I think community and primary care GPs, it should be all one and the same thing.
Well, sorry, can I just interrupt you there? Because that's quite important as well. Because a lot of community services, nurses and what have you, ended up in a hub away from the GPs. I know when Virgin ran it, all the doctors complained that they couldn't get in, they couldn't talk to the community nurse because so much of what you can learn about patients and what's going on is over a cup of tea in the surgery. So are your nurses in the surgeries?
Yeah, so we went through a period of centralisation years ago, and my GP colleagues have always said to me, can you give me back my community nurse, my practice nurse, whatever resource was centralised. And I've really listened to that because I think there's absolutely value in it. I think the new and emerging integrated neighbourhood teams are a really powerful way of delivering care at that local level. So I really want to completely decentralise and put the right resources into that locality or primary care network or however you want to define it. But it's wider than just community and GPs. I think the local authority need to be sitting alongside us with mental health partners in our voluntary sector. So I think we've got some great pockets of it. We've still got a way to go to get all of the teams localised. And there's big enablers for that, isn't there? There's the estate itself that's an enabler, the digital enablers, which is why I was saying I'm really interested in the logistics of that. But a starting point is that you're all looking at the same information on your local residents and responding in the way that you should collectively.
It's really interesting. Right, has anybody got anything, a quick comment you want to make, or is anything that you want to ask? Now is the time to do it. Okay, we've got, let's have a look, we've got about 120 seconds left. Are you optimistic for the future? What do you think? Do you think ICBs are the right way?
Whether they are or they're not, I'm optimistic for the future because, you know, I've been at NHS for 35 years.
Yes, you've had all the optimism genes removed.
I think working with the wider partners has given me more optimism, yes, most definitely recently.
And is the future bright?
The future's very bright, and we're all optimists on a daily basis to try and sort this out and just be a little part of a big jigsaw puzzle to try and help patients navigate the system.
Well, we're all here for the same reason, aren't we?
Yeah.
Ladies and gentlemen, I hope you found that interesting. I did. Can we say thank you to our ladies? Thank you. Thank you very much.